Good afternoon, everyone. Welcome to the clinical combined rounds under the Department of Neurology. Yeah, so we are presenting case of late onset progressive proximal lower limb weakness. It's a case which we all likely to see in medicine, in neurology, in the outpatient clinic. And the patient has been evaluated in multiple centers in Delhi itself. So let's see what it turns out to be.
So we are going to present the case of Mrs. X, who is a 75-year-old female. She's right-handed and she was an accountant in Air India and was now retired. And she presented to us with a total duration of illness of approximately 4 years, and she developed weakness in bilateral lower limb since 4 years and weakness in bilateral upper limb since last 1 year. Initially she developed weakness in bilateral lower limb, and as we can see from the chief complaints, the patient had proximal predominant weakness, which was progressive as the years progressed. And in 3 years into the illness, she started developing weakness of bilateral upper limb as well. In addition to that, she also had difficulty swallowing food, which was more for solids than liquids. This also started 3 years into the illness, such that she had to take extra fluids and semi-solids in order to swallow food. But this was not associated with any fatigability. This was not associated with any jaw claudication, and neither there was any fluctuation in other complaints as well. Regarding the relevant negative history, she had no difficulty turning neck side to side. There was no sensory complaints. There was no history of any pain, no history of thinning of limbs, fasciculations or cramps. There was no history of any chronic fever, weight loss, and no history suggestive of photosensitive rash or Raynaud's phenomenon. So this is the summary of the complaints. So the complaints, as we can see, started in 2020. Initially, she had only difficulty getting up. Then she started needing occasional support. Then she could not get up with support, and then she had difficulty getting up of stairs, and finally she had difficulty in walking. This is the point she came to us. And in 2023, she also started having difficulty in swallowing and difficulty lifting hands above the head. So basically, it's a proximal weakness. So the relevant past is she had a long past history. In 2008, she was diagnosed with diabetes, and then in 2009, what she gave was history of palpitations. So it sounded like hyperthyroidism, but we did not have any records of that time. Then in 2011, she underwent thyroidectomy for the same, and since then she has been on thyroid replacement therapy. Then in 2018, she had AUB, for which she was diagnosed with uterine fibroids and also diagnosed with CA endometrium. And then she underwent DHBSO in 2019, and she received 5 cycles of brachytherapy, and it was done with curative intent. Then in 2020, she started having these complaints. Then she had shown in outside hospital and was diagnosed to have elevated creatine kinase, and statin-induced myositis was suspected initially, and statins were stopped, but patients still worsened despite stopping statins. No relevant personal history as such. This is the family history. As we can see there in the labeled with red is our index patient, and her mother had history of CA esophagus, and her maternal uncle had history of malignant nerve sheath tumor. So in order to recap, as we can see, she from 2009 to 11, as we can see, patient underwent thyroidectomy for hyperthyroidism, for which she had taken propranolol, and now she has been on thyroxine. And since 2008, she has been on oral hypoglycemic medications, antihypertensive medications, and she took statins from 2011 to 2020, after which it was stopped after the weakness started. So, summarizing the case, it is a 75-year-old female, 22 years diabetes and 22 years of diabetes and 14 years of hypertension, history of thyroidectomy on thyroid replacement, and then we see the keywords. Since she has presented to us with insidious onset, the weakness is gradually progressive, it is proximal predominant, it is symmetrical, it is non-fatigable, it is lower motor neuron type and pure motor for lower limbs and upper limbs, then associated with bulbar weakness as well. So she presented to us at MRS2. So let's break down the salient keywords, and let's try to localize these symptoms. So let's start from below. It's a lower motor neuron type of weakness. So all upper motor neuron localizations are not there. So we'll go to, so the next, it was a pure motor weakness. So we will think of only pure motor localization. So radical plexus and nerve cannot be our localization in that case. It was a non-fatigable weakness. So neuromuscular junction is less likely. Then it is a proximal predominant weakness. So anterior horn cell also becomes less likely. So that leaves us with muscle. So our localization was muscle. And so now, since we have localized it to muscle, let's think of the causes which could have led to this. So this was the summary which I told earlier, and we can think of a few causes straight away. She had underwent thyroidectomy, so she was hypothyroid since 2011, although she was receiving thyroxine. Then she had history of CA endometrium, and she was taking statins. So straight away, some of our possibilities are it could either be hypothyroid myopathy. The second possibility, it could be paraneoplastic myopathy, and because it was diagnosed after CA endometrium, and it is also it could be statin-induced myositis, and we have a whole range of statin-induced myositis, a whole continuum of diseases which could have led to this. So these were the possibilities we considered. In addition to what I told right now, there other possibilities considered were because she's a 75-year-old female. She could also be having a monoclonal gammopathy associated myopathy at this age. We would consider that as well. And inclusion body myositis was also considered, but the patient did not have any inclusion body myositis type pattern of weakness. And she also developed, and other possibility could be limb girdle muscle dystrophy late onset, because it's a proximal predominant weakness. So based on, let's keep these differentials in mind, and let's come to the examination. So on examination, her general examination was more or less okay. Then systemic examination was fine. CNS examination, in the cranial nerve examination, there was weakness of sternocleidomastoid and trapezius bilaterally. So she had proximal weakness as well. Motor examination mein, notice that in the proximal parts of the upper limb and lower limb, there is mildly reduced tone, but this normal tone in the wrist and ankle, and bulk wise it's fine. And here also we can see a pattern. There is the proximal neck and upper limb muscles are weak, but the distal wrist and hand grip are normal. Then similar pattern can be seen in lower limb as well. And rest of the examination, sensory, cerebellar, extrapyramidal, cranium and spine were normal. So let's look at the gait examination. This was the gait when she came to us. So she's having difficulty getting up without taking a support, and she has to bend forward excessively in order to get up. But now once she's up, she's able to walk now normally. So this was her complaint at that time, and she's slow also while walking. And what she told was she has an apprehension of fall as well, that she will not be able to support herself in case she falls. So these were the preliminary investigations. We did. Here, most of the investigations were normal. As we can see here, ANA, ANCA, the rest of the CTD workup, connective tissue disease workup has been sent, which is normal. CA markers are normal. Rest of the workup is normal. We did an EMG. It was suggestive of a myopathy pattern. 2D echo was done, which was normal. And CK as we can see is 3600. So CK was elevated. So again, now we did an MRI muscle of the patient, and I would like to call Dr. Suraj to discuss the radiology part of this.
Good afternoon, everyone. Thank you, Dr. Anish, for inviting me. I'll present the radiological part of this case. So these are the T1 Dixon images of hip muscles, superior section and the inferior section. Here we can see the diffuse T1 hyperintensity involving the bilateral paraspinal muscles and the gluteal muscles, which represent the fatty infiltration associated with mild volume loss of the muscles. The middle one is multifidus and the outer one is erectus spinae muscle. Same T1 Dixon image, but the thigh section, superior thigh section and inferior thigh section. Here we can see very mild, discrete kind of fatty infiltration with mild volume loss involving the posterior compartment of the thigh muscles. These are, the medial one is semimembranosus, then semitendinosus, and the biceps femoris, long head. And the inferior section shows the short head of the biceps femoris. Now after T1, we'll see T2 images of these sections of bilateral thigh. We can see the diffuse involvement, diffuse hyperintensity involving the anterior and the medial compartment of the bilateral thigh muscles. These are vastus leptalis, vastus intermedius, vastus medius, and adductor magnus and adductor longus muscles. which represent this hyperintensity represent the edematous changes of in these muscles. We lower down T2 Dixon image of bilateral leg muscles. We can see the similar finding in one of the leg muscle, medial posterior compartment of muscles called medial gastrocnemius, anterior part of the medial gastrocnemius muscle bilaterally. Post-contrast image of this shows the subtle enhancement which represent the active nature of the disease. Similar finding edematous changes are also seen in the shoulder muscles, left shoulder muscle and the arm muscle. These are the posterior head and inferior spinatus muscle of left shoulder and tricep muscle of left arm. Thank you. For PET finding, I'll call the nuclear medicine.
Good afternoon, everyone. So going into the PET images, so as we can see the maximum intensity projection image of this patient, apart from the normal physiological distribution of the FDG, we see abnormal increased FDG uptake in the upper appendicular skeletal muscles and the lower appendicular skeletal muscles as well as the paraspinal muscles. Going further ahead, into the coronal PET-CT fused images, we can see there is very diffusely increased FDG uptake in the shoulder girdle muscles and the lower limb muscles. And going further ahead, we can see there is diffusely increased FDG uptake in the bilateral trapezius muscles. So with the given clinical context, we would think in terms of an inflammatory myopathy.
So as Dr. Suraj and Umran pointed out, there was active disease in the proximal upper limb muscle in the deltoid. So we had done a biopsy of the deltoid and sent it for review. But before discussing that, the patient had also underwent a muscle biopsy in 2024 in outside hospital, and it only first review showed a mild variation in size of muscle fibers. It did not have any inclusions and no inflammatory cells. But that block was reviewed again in an outside hospital only, not at AIIMS, and that showed dense fibrocollagenous tissue, and it showed chronic inflammatory cell infiltrate and fatty infiltration as well. So in the context of that, I'd like to call Dr. Amrita to discuss the pathology.
So in 2025, we received a specimen labeled as muscle biopsy measuring 0.4 by 0.3 by 0.2 centimeter of a 75-year female with a clinical diagnosis of HMG-CR myositis versus paraneoplastic myopathy. This is a low power view where we can see there is a partial loss of muscle fascicular architecture and there is a adipocytic infiltration. This is a high power view where we can see there is a mild variation in the fiber size. Few regenerating fibers are there with the internalization of nuclei. There is a minimal inflammation in the endomysium and around the myofibers, and some degenerating fibers are also present. This is another section where we can see the necrotic myofibers having pale eosinophilic cytoplasm and flocculent cytoplasm. On immunohistochemistry, MHC class 1 is upregulated, which suggests an immune-mediated process. MHC2 is not upregulated, which rules out the polymyositis. MAC and MXA1 is negative, which rules out the dermatomyositis. CD3, CD4, and CD8 positive cells are seen around the myofibers, which indicates the T cell inflammatory infiltrate, while CD20 is negative, which is an B cell lineage marker. Few cells are positive for P62 and LC3B, which is autophagy markers, while CD56 highlights the regenerating fibers. So based on the histomorphological features and presence of necrotic fibers and minimal inflammation, the diagnosis was immune-mediated necrotizing myositis. On urine immunoblot assay shows positivity for HMG-CR, which confirms the diagnosis of immune-mediated necrotizing myositis.
Based on the biopsy, we have almost placed the diagnosis of HMG-CR myopathy, including the immunoblot. However, when we were managing the patient, the immunoblot was not available right away. So we also sent a whole exon sequencing for the patient as well, because limb girdle muscle dystrophy was also in our differentials. it did not reveal any significant abnormality. Then we sent a myositis panel. This is the myositis panel for dermatomyositis antisynthetase syndrome, and here we can see for immune-mediated necrotizing myositis, HMG-CR is 3+. It is strongly positive as it was in the immunoblot, and this was the paraneoplastic panel as well, but this was negative. And this was another, we sent it to 2 labs actually, and both labs showed HMG-CR-CoA reductase positive in antibodies. So our final diagnosis is anti-HMG-CR antibody myositis. And after the diagnosis, we discuss. So HMG-CR is a rare disease, and there are no consensus guideline as to how to manage this. There are only anecdotal case reports and case series. So the treatment options we discussed with the patient were we could give a trial of IVIG and methotrexate, and if it doesn't work out, we can start the patient on rituximab. So the patient agreed for IVIG and methotrexate. So we started the patient right away on monthly IVIG. An option of pulse methylprednisolone was also discussed, but since the patient was already dyslipidemic and she also had diabetes, it would have put her at a significant risk. So we straight away went to IVIG. So monthly IVIG and methotrexate was given, and methotrexate was up titrated from 7.5 mg to 15 mg per week. So this was the treatment we gave. We started the treatment around February of 2025. And till now she has received monthly IVIG. Since August she missed 1 dose, but after that she again came for IVIG in September. And as we can see, the initial CK was 4017, and we can see that the CK values have steadily been dropping, and the latest CK value is 562. So, and the patient has also improved as well. So let's look at how the patient has responded. Along with that, we also did monitoring because the patient was on methotrexate, and we did monthly pulmonary function test and monthly DLCO. This was a very overzealous monitoring for methotrexate. Usually the guidelines say for methotrexate we do a 3 to 6 monthly pulmonary function test and DLCO, and once after it is normal for 1 year, we can do a monthly monitoring. So this was the patient course over the treatment. So the baseline we have already seen how she was having difficulty in getting up. Now we will see the post IVIG 1 month, and we'll see whether she has improved or not. So she's now able to get up. Her speed of getting up is much better, and she was walking fine before also, but now her speed of walking has also improved. Her confidence in walking has also improved, and now we can see 6 months the patient has improved without support. She's able to get up. Her walking speed has increased drastically. So this is the improvement we have seen from February of 25 to September of 25. So let's discuss what this disease entity is and why this needs to be discussed. So let's go start from a brief history. Initially, the first statin which was discovered was lovastatin, and once these statins started getting used, we started seeing statin-induced myositis, and we had a whole continuum of statin-induced muscle diseases. We'll look at that. So this is the whole continuum of statin-induced myositis. So statin myotoxicity, it could either be asymptomatic, can only present with myalgia, it can only present with myopathy or rhabdomyolysis. Then the rarest form is immune-mediated necrotizing myopathy, which our patient has. And as we can see, this does not resolve with statin cessation, but rest of all the diseases fully resolve with statin cessation. And it's not if patient is not receiving statin for last 2 to 3 years, the patient cannot develop this. There is an asymptomatic period, and there is a delay. The delay can range anywhere from 3 months to 14 years after this statin cessation. So our patient had that as well, and the CK is more than 10 times upper limits of normal, and anti-HMG-CR is present only in this immune-mediated necrotizing myopathy. So giving a brief pathogenesis, what it does is, because the statin is inhibiting HMG-CoA reductase, there is upregulation of those molecules, leading to a loss of self-tolerance that causes autoimmunity. And there are specific HLA markers which are associated with this disease. And there are multiple forms of this disease as well. There's a juvenile onset form, there's a typical adult form, and there's an atypical adult form. So the typical adult form has this HLA DRB1 1101, and 701 is for juvenile. We'll see that. And this I told you about the phenotypes: classic adult onset, atypical adult, and juvenile. As we can see, adult onset is acute to subacute, and dysphagia occurs now commonly, which we had in our patient. Extramuscular weakness, extramuscular manifestations. I'll come to that. Patient can have cardiac manifestations. They can have skin manifestations like dermatomyositis. There's even reports of Gauthrin's papules in HMG co-reductase. So this is mostly seen in the juvenile form, skin rash. And we can see HLA association, as I mentioned, 701 is in juvenile and 1101 is in classic adult onset. So our patient basically fits into the classic adult onset from marked proximal weakness and dysphagia. So let's look at our current knowledge on this entity, though limited. So does everyone consuming statin develop antibodies? The obvious answer is no, and the overall incidence is very low. The incidence is 2 per million population. And but now there is an increasing incidence, probably due to increase in testing and awareness regarding the disease. And there is also an interesting phenomenon that there is low statin exposure exposure percentage among Asian cohorts, not as much as in Western cohorts. So the hypothesis behind that, as of now, is that the food in Asian population, mostly in Chinese population and in Indian population, the food contains natural statins. So even the patients who are statin naive in Asian subcontinent and Asian continent, they may still develop statin-induced myositis even if they haven't been exposed to statin till now. So the extramuscular manifestations of this were dysphagia, which our patient had, cardiac involvement, for which we did a 2D echo as well, and cardiac involvement happens in form of conduction abnormalities, diastolic and systolic dysfunction, and as I discussed, skin disease, hypo and hyperpigmentation can be present, and Gauthrin's papules like lesions can also be seen in a juvenile variant. So how is this disease correlated with statin exposure? As I told, that there is a long latency period, 2 months to 14 years, with a median latency of around 3 years, and it may occur even after ceasing statin therapy, which has actually happened in our patient, although it was stopped and it still progressed. So these are the studies which show how long is the latency, how varied is the latency from statin exposure. So there is genetic predisposition as well. There are certain variants of HMG co-reductase gene. So this is separate from HLA. HLA gives how many patients might develop an autoimmunity to that. And HMG co-reductase gene, there are some variants in HMG co-reductase gene which are more likely to develop this disease, and they are being investigated. So let's look at another entity. This is HMG co-reductase genetic myopathy. This is not an immune-mediated necrotizing myopathy. If the patient has a double hit in HMG co-reductase gene, if the patient has a biallelic mutation, then also the patient can present with a myopathy. And this flowchart shows the pathway of HMG co-reductase gene. So HMGCR helps in conversion of HMG CoA to mevalonate. So in the in the biallelic mutation variant, there is evidence to say that if we supplement the patient with mevalonate, the myopathy may actually improve. However, this is also being investigated. And in case the patient develops a biallelic mutation and HMG co-reductase, HMG CoA genetic myopathy, this is the phenotype. The patient may have high CK levels, waddling gait, limited ambulation, proximal muscle weakness, and atrophy. So it is more like the disease we also see. So this will be a differential for our patient as well. Although the presentation age is a bit less, so our patient had HMG co-reductase antibody. So let's look at a cohort of patients. This was a study which was done, and a cohort of patients which were evaluated. This was a short cohort of 6 patients. As we can see, from the small lowest age was 12 years and the highest stage was 48 years. And the patient had dysphagia, elevated CK. CK was abnormal, 3,000, 11,000. This has also gone to 13 to 20,000. And as we can see, this patient is 13 years of age, and see he has the 701 HLA as well, whereas other older patients are having 1101 cohort as well. And this patient had also taken mushroom supplements in her 20s. So this could also be a statin naive patient which had received natural statins. And this was the treatment offered to these patients, IVIG, and this patient had also received methylprednisone. And most patients showed significant improvement over the course of their follow-up. So as natural with the myositis, how much should we be concerned with the risk of malignancy? So current consensus guidelines says that it is at an intermediate risk of malignancy. So it needs basic and in some cases advanced cancer screening. So basic cancer screening will be age appropriate and gender appropriate, like X-rays. We should do a pap smear. And once basic is normal, we can go for advanced screening with PET. If we are suspecting any lung malignancy, if there is high index of suspicion, we can go for dedicated imaging for that as well. So advanced cancer screening is required in some patients, but basic should be done in all patients, which we did. And one more important thing is these patients will be old, these patients will be dyslipidemic. So should we avoid statins in these patients? And if so, how should we treat the hyperlipidemia? So as of now, the common practice is to stop statins straight away after diagnosis, but there is still a lack of evidence which says whether statin cessation actually improves outcomes, or if we continue the statins, they may have a worse disease. There's no evidence to say that. But as of now, we just switch to a non-statin cholesterol lowering agent. But there have been some cohorts who have tried successful re-challenge of statins in these patients, and there's a whole data on which statins are more likely to cause this myopathy. And if the person was, suppose, let's say, on atorvastatin, and the patient developed this myopathy, they can be re-challenged with another statin as well. But this still needs investigation. And this is, as of now, the consensus guideline for treatment is this. So we start with IV glucocorticoids, methylprednisolone, followed by a taper, and we give methotrexate, azathioprine, or MMF. In this case, we gave methotrexate and IVIG. So we straight away started from the second step. And if the patient is still not responding, we can give rituximab. This treatment option was also explained to the patient. So this is what we know about this disease as of now. And so finally, the take-home message is statin-induced myositis is a rare, but it's a manageable cause of muscle weakness in a growing number of patients. And early recognition and treatment are important. Before it goes into complete fatty infiltration and we are not able to help the patient, we should have a high index of suspicion. And in this age group of patients where the patients may have proximal muscle weakness and we straight away label the patient as some form of LGMD, we should also look for treatable causes so that we can improve their quality of life, especially in their older years. So we should keep a low threshold of suspicion for diagnosis, and we should also look for other treatment options which are still emerging. And yeah, that's it. Thank you.
Thank you, Anish. I mean, this case shows that an elderly 75-year-old coming with proximal weakness and multiple comorbidities cannot be labeled as still like a hypothyroid myopathy. She was roaming around for a diagnosis of hypothyroid myopathy. Later on, did a biopsy and labeled as a muscular dystrophy. She came to me as a case of a muscular dystrophy. So this is in fact, when we presented our LGMD data and WMS, Carl Sponeman, who has the largest cohort of HMGCR antibody, who came in and did you test all your negative cases HMGCR antibody, which is a standard practice across the world now. If it is an exome negative limb-girdle muscular dystrophy, you test for HMGCR antibody in all patients. It's a treatable thing, which should be done. I think it should be interesting for all clinicians. Thank you.
Thank you, Dr. Vishnu, and I have the permission of the neurosurgery department. It's with mixed emotions. As you would have realized, the case involved multiple disciplines, muscle immunology and pathology. So it's with mixed emotions of both sadness and gratitude that I take this as a special occasion of being the last CCR which Professor M.C. Sharma has come for, and it's really to bid farewell and honor him for his support, particularly as being one of the pillars of neurosciences and helping us out with all the queries and all the problems in neuropathology. He and his team have established a wonderful department which is so amicable to access at any point of the day. So we would want to honor you, and I request Dr. Vishnu and Dr. Rohit to come forward to do the pleasant formalities, and of course the neurosurgeons can of course join us because it's a joint team. So request HOD Neurosurgery and Dr. Deepak Agarwal. Thank you, sir, for being here. I know that it's a loss for us, but I'm sure we'll be able to, contact you at any point of time for any of our problems that we face.
would also like to give this was the last CPC for Indian Academy of Neurology. He has been our CPC master for long years. As a token of remembrance to the last CPC. Was kind enough to come and give our first neuromuscular.
Thank you for that.
And last but not least, this was given by the patient, the patient who we treated. It was given as a gratitude by the patient to the treating team.
Thank you.